Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice in any situation. Please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you are unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
So let's move on to a scenario that the OSCEmaster will go through with us. And hopefully, if you're a pre-reg waiting for your OSCEs to come by, you'll learn something from this as well. But also be a little taster onto how the OSCEmaster kind of functions and how the sessions will kind of look like. So if it seems like it's something good for you, then you can tune in and book some sessions with Abdul. So Abdul, if you can just share your screen and we can just go through that scenario.
Right, so we'll go through a scenario that you can actually have access to on the college website. So their sample OSCE station. Right, so the information you can see on your screen, this is known as the candidate instructions. So the actual OSCEs, you get 1 minute to read this information. So this will be on a sheet of paper outside the room. So you've got 1 minute to read this information. So obviously ensure that you read it carefully. And what you want to be doing is looking and highlighting key terms. So if you all just have a brief, quick read of this scenario. So essentially, we've got a patient who's attended practice because he has noticed a sudden onset of flashing lights in his right eye. They have ceased by the following day. So this is a 53-year-old male. He hasn't experienced anything like this before, has no other symptoms. History unremarkable, general health is good, doesn't suffer from headaches and has not suffered any trauma, no family history of eye problems. So it tells you that you've conducted a full ocular examination, read the record card showing your results, explain to the patient what you have found, what might be wrong with him, and what you recommend. So this is a communication station where we're having to communicate a condition to a patient. So in that 1 minute, what are the key terms in this scenario? So first of all, his age, I'd say, is a key term, a 53-year-old male. And what are the symptoms? The sudden onset nature of these flashing lights, and these flashing lights are unilateral, so it's only affecting one eye. There's no other real symptoms that have been mentioned in this clinical record card, sorry, in these candidate instructions. The information we've been given, in that 1 minute, I need to be thinking to myself, what could this be? So I'm thinking in my head, what are the potential diagnoses it could be? So what could it be with flashing lights? What conditions are we thinking?
So I mean, flashing lights, you'll instantly go into PVD, retinal detachment, retinal tear kind of territory, aren't you?
Ocular migraine could also be a case.
Yeah, exactly. So they're the three main conditions that I'd be suspecting: retinal detachment, retinal tear, PVD, and visual aura migraines or ocular migraines. We obviously need more information. I don't think we can get a set diagnosis just from this information. But if it was myself, ocular migraines tend to be sort of bilateral, whereas this is unilateral. And with the retinal detachment and PVD, we're at the right age, around the sort of 50 plus. With the retinal detachment, I'd be expecting more symptoms. So maybe floaters, maybe curtains, maybe veils over the vision, maybe some form of trauma as well. But like I said, we can't make a diagnosis just from this information. That's why we need to go into the room where we're given further information. And this is in the form of a record card. So this is the record card that you'd be provided.
And this is within that 5 minutes mark, isn't it now?
Yeah, so once you've read the candidate instructions for 1 minute, the speaker will announce you may now enter the station. You go into the room and often you'll see the examiner first. They'll just check your lanyard, ensure you're the correct person, and then they'll direct you to the desk. On the desk, you'll have this clinical record card you can see on your screen, and you'll also have access to the candidate instructions as well again. The first thing you should do in this station, in any station where there's a patient involved, is introduce yourself to the patient. Because believe it or not, you actually get marks for that. So hello, my name is Abdul. Today I'll be your trainee optometrist. If you just give me a moment, I'm going to read through your record card and I'll be with you shortly. Then you need to read through this record card, take 30-45 seconds, and then go back to your patient and deliver your answer. So when I'm reading through this record card, I'm seeing if there's any links from the clinical tests to the conditions that we're suspecting. So retinal detachment, PVD, and visual aura migraines. We can see that the VA is at a very good level. They're equal. We've done the refraction. There's no RAPD. IOPs are normal and equal. Full visual fields. No signs of Schaefer's, and no retinal tears or floaters noted in the dilated fundus exam. So from this information, we can rule out a detachment. So we can rule out a retinal detachment. That leaves the most likely diagnosis as being a PVD, posterior vitreous detachment. So the next part is having to explain that to our patient. So this would be a communication station explaining PVD to Mr. Joseph Rollins. So how do we do that? In terms of the structure, I advise students to break your answer down to 3 parts. So a little bit like a story. Part 1, part 2, part 3. So part 1, you want to confirm the symptoms and discuss your clinical findings. Part 2, you want to give a diagnosis and any risk factors. And part 3, you want to give appropriate management. So part 1 was confirmation of the symptoms and discussion of your clinical findings. So what are the symptoms? Why is this patient here today? So the reason why this patient is here today is due to the flashing lights he's noticed. So that's what I'd start off by mentioning. So Mr. Rollins, I understand you have attended today due to these flashing lights you've noticed in your right eye. I'd follow that up by reassuring the patient that they've done the right thing coming in today. So you'd say something like, I appreciate this may be quite concerning, but you've done the right thing coming in to see us today, as I've done a full thorough examination and I'll just describe to you what I found. And then you want to talk about the clinical findings, which is basically the record card you were provided. And you want to just mention a few of the clinical tests that you've done, which is relevant to finding signs of retinal detachment, PVD, or visual aura migraines, which is pretty much all them clinical tests, except probably the optic disc analysis. So you can mention to the patient, we have assessed your level of vision and we found that it's equal and at a very good standard. We assessed how well your pupils react to light and they appear normal. We assessed the pressures within your eyes. They were also within normal limits and equal. We assessed your field of vision when you press the clicker in response to the lights. That assesses your vision from the center right out to the edges, and that was all normal as well. We also looked for cells that can appear in front of the jelly of the eye, and there were no signs of that, and that can sometimes indicate a tear at the back of the eye. And finally, we carried out a exam that looked at the back of the eye where we were identifying any tears, any breaks in the retina, the light sensitive layer, and that also came back all clear. So you've discussed here the clinical findings. So if I was to go to the marking points, let's see what we've covered, which I believe is here, the objectives. So I've mentioned that there's no evidences of a retinal tear or floaters. I've talked about the clinical tests that we've done. I've not done this part yet, but I've introduced myself to the patient.
Well, I hope you were polite, considerate, and respectful.
And I've also reassured them appropriately. So that's part one done. So part two of the story for this answer would be giving a diagnosis and stating the appropriate risk factors for this condition. So the diagnosis is obviously a posterior vitreous detachment, but we need to explain this to the patient in layman terms, so in a manner that they can understand. And again, every student will have a different way of doing this. So I would explain it in the way of describing the part of the eye affected. So that's the vitreous gel. So you can say to the patient, I feel that this is caused by a natural change within the eye itself. So within the eye, we have a gel known as the vitreous, which helps maintain the eye shape and also makes up about 80% of the eyeball itself. As we age, it's very common for the vitreous gel to become a less solid and more watery, so less like a gel. And when this happens, it can start to shrink and it can start to come away from the back of the eye. When it pulls away from the back of the eye, it can cause little flashes to occur as it pulls away from the light sensitive layer, the retina. And that's what you are noticing today. Then you want to give risk factors. So you can mention the main risk factor is the patient's age. So we see this more commonly in patients over the age of 50, and he's 52. And also the fact that he's myopic, so she's short-sighted, and that is another risk factor for this, because the patient will want to know, why is this happening to me? And then the final part of the story is just the management. The management is, how are you going to help this patient? What are you going to do? Does it require a referral? In this case, first of all, you want to reassure this patient. So reassure them that this is just a natural change that occurs within the eye. It's nothing sight-threatening at all. And follow that up with SOS advice. So what to do if the symptoms progress into something of more of a sight-threatening nature. For example, if they were to notice new onset of floaters, curtains or veils over the vision, etc. You'd finish this off by offering the patient a leaflet. In the OSCEs, you can just do like a pretend leaflet, and then asking if they've got any questions and if everything basically makes sense from what you've explained.
Do you find that doing these courses or holding these seminars, do you find that that keeps you fresh and keeps you, at the high level that we're expected to be easier when you're in your normal practice as a optometrist?
Yeah, definitely. So it keeps your knowledge fresh, because before exam season starts and before I actually start carrying out these OSCE sessions, I do have to look over all my content, look over my notes, even the practicals, because students are asking me questions and they can be practical related. I'm having to look over that, and it's often like skills you don't really use as often. For example, the other day someone asked about like fixation disparity at near, how you'd sort of do that, because it's not really a test that we use that often these days. So it does definitely keep your knowledge fresh doing these OSCE courses.
With this scenario that you went through, is that something that you do once, let's say, all of the pre-reggers have kind of given their own answer? Like, would you go over it like that when they've kind of done everything, or do you start it at the beginning and then see what they say, see how they perform after you've gone through that?
Yeah, so I'd go through the sort of feedback and the model answer, if there is one, once the student has attempted. attempted the station. So yeah, this would be part of the feedback.
Cool. Thank you very much for that, Abdul. I think a lot of the pre-regs that have probably been practicing for the OSCEs have probably come across that scenario. And they've probably read through that kind of mark sheet as well. But the way that you kind of go through it and break it down step by step, I think is the bit that maybe some of the pre-regs might be missing on a little bit. So I think that was quite insightful into the way of thinking when you're attempting that OSCE station. Just obviously, this is more of an explain to the patient on, let's say, something that's relatively normal. Is there any differences to how it's marked for other forms of communication? Let's say, for example, with taking a history or something like that. Is there any other main pointers that they would want to be covered, or is it more on that kind of same mark sheet?
Yeah, so that mark sheet would be for a typical explaining a condition to a patient. For different scenarios like a case history, the marking aspects, the marking points will be sort of totally different. They'll be looking for different aspects to this station.
With the communication stations, is there anything from that mark sheet that's just unilaterally, like universally, like in every single station that you need to like have every single time?
Be polite and courteous.
Yeah.
Yeah. But I mean something a bit more specific.
The introduction, I always bang on about that, but that's very important. Very easy to forget about as well. Polite and courteous, reassures appropriately. Also, your answer being logical. That's why I always advise have a good structure to your answer, because you don't want to jump from one point to another point where there's no sort of logic involved. So your answer having a good structure is also sort of universal.
And then just the final point, the question, what would you advise to the pre-reggers that in the middle of the OSCE, they kind of have a brain fog and they don't know either how to answer or they forget what they're even talking about? What would you advise those kind of pre-reggers that kind of feel like they might be prone to that experience or have experienced and like resitting their OSCEs?
Yeah, I mean, it's quite common. It's that exam stress, that pressure in that environment that you're in. And when your mind goes blank, it really can go blank where you don't know what to say next. My advice would be, obviously, if you've had a bad station, try to forget about it as best as you can, because thinking and dwelling about it is not going to allow you to go back to it, revisit it, and score higher. It's done. So forget about it. Move on to the next one. Otherwise, it's going to affect the next few stations. If you have a scenario where you've got no idea of what a condition is, what the pathology is, have a go, because the marking is different for each station. You might only get certain marks for the actual diagnosis, whereas more marks may be available for like a description of an image. So still attempt every station, even if you have no idea of sort of what it is. And just try to believe in yourself. Remember, you've got to this stage because you've earned it. You've passed university. You've gone through all 3 stages. So you have a right to be there to sit this exam. If you didn't have the skill set and the knowledge, you would not be sitting your OSCE exams.
I also think there's an interesting thing that you said about attempting it, because your OSCE results, it's not just the stations you pass, it's also an overall mark. So even if you fail it, it's still tallied onto that overall mark. Is that right?
Yeah, that's correct. Yeah. So you can either fail your OSCEs based on the number of stations you've passed or the number of marks you've gained altogether. So yeah, the worst thing you can do is not attempt it, because then obviously you're going to get 0. But even like in a case history example, in a case history scenario, it's not just about getting the diagnosis. It's about the questions, your full thorough case history, the questions you ask, which will also contribute to your marks.
Can you pass like a case history if you get the diagnosis wrong?
Yeah, definitely. Yeah, I get a lot of students ask me. I've done this case history. I got the diagnosis incorrect, but I still passed. How did that work? And it's likely because of the weighting of the station. The weighting of the station must have been more on the questions rather than the answer. So your questioning must have been really good, the actual case history, for you to sort of pass that scenario.
Thank you very much. Usman, do you have any other questions at all? Or
Yeah, I mean, this was my first little OSCE training thing, and I really,
this is where he starts bragging about how he passed everything first time without any further
I don't
help.
need to. He's doing it for me. I don't have to. It's but I really like that structure. When you're going through it and you're saying for the structure, go over what they mentioned in the beginning, why they're here, then bring up what you're experiencing, etc. Because naturally, sure, as optometrists at this stage, we'll do that in how we speak, etc. But especially back then, I would have, you're just winging it really at that stage. So to have that structure and to just go in, and I would imagine that you would be blanking a lot less if you're like, okay, I've got 3 things I need to cover. And it's like, just cover the first point, then we can move on to the second point. Cover the second point, then we can move on to the third point. And just to have that confidence because you have such a solid structure that just breaks things down and you just literally have to, fill in the gaps with a couple of words here and there because it's all been given to you. I really like that. I really like that.
Yeah, a structure is very important because it reduces the chances of your mind going blank. Because after I've mentioned this, I need to mention the management, so you know what's coming next. And the most important part is it allows you to hit all the marking points as well that the examiners are looking for. And essentially that's what you're wanting to sort of pass that stage and get a score as high as possible.
You're kind of telling them how to think for the OSCEs rather than telling them how to do the OSCEs, basically.
It's impossible to tell them all the answers. You can just tell them.
Yeah, but like I don't know. I feel like it's more like this is the mindset that you need in order to pass your OSCEs, because it's not like stage 2 when you just have to know everything and then answer the questions.
Yeah, exactly. So a structure like that, you can apply it to any condition, whether it's a PVD or a retinal detachment or glaucoma, and you can still apply the same principle and allows you to still score high. Because I've had many students that are sort of sitting the first mock sessions for the first time with myself, and when it comes to a station like that, they just don't know where to start. So once you have a starting point, the rest of it can just sort of flow naturally from there.
Where should people go to find you?
So you can contact me on Instagram, OSCE_master. Or if you don't have Instagram, you can contact me via email, OSCEm313@gmail.com.
Super. Thank you. Thank you so much for your time. Thank you for especially going through that little station with us. And I'm sure everybody listening will be very grateful for the discount code as well.
What was this discount code again?
GHF10.
Perfect. That's for the July OSCE. And that's for the July OSCE for 2+, for 2 stations plus.
July 2025.
Yeah, not every July OSCE. There's only a couple more, to be honest.
Yeah.
But, okay, then. That's it from us. Thank you again for listening, and we'll see you next time.